Hello, my name is Bharati Kochar. I'm a gastroenterologist at the Massachusetts General Hospital and assistant professor of medicine at Harvard Medical School. I'll be speaking to you about the management of the older adult with IBD. In about 20 minutes or so, we'll briefly cover aging and IBD, talk about IBD medications in older adults, and review some comprehensive care tips for older adults with IBD. So to start off, if you're anything like me, you may be thinking, I'm a gastroenterologist. Why should I care about aging? But whether you want to or not, we all need to be caring about aging because in the next decade, the number of adults 65 years and older will outnumber the number of children in the United States. Globally, this has already happened. Despite this, there is a decline in the number of geriatricians per capita projected in the United States over the coming decades. Given this dearth, the majority of adults in the country will not be seen by a specialist in aging, and so that burden falls on us as specialists to understand aging in our subspecialties and provide that tailored care. So even if you may not have ever been interested in geriatrics, our clinical practice mandates that we pay attention to geriatrics. It's very important to recognize that many older adults are healthy. This is a summary figure from a review of pooled data from 14,000 community dwelling older adults. And what it shows here that nearly half of older adults are neither frail nor multimorbid. 42% are multimorbid, defined as having two or more chronic diseases. And while many who are frail are multimorbid, not all of frailty is actually due to multimorbidity, and not all of those who are multimorbid are frail. So as you're seeing your older adult, it's important to remember that frailty does not equal disability, which does not equal multimorbidity. Geriatrics, like pediatrics, is actually a field of its own. But unlike pediatrics, people of the same chronologic age may not have a similar biologic age. These figures here highlight the heterogeneity in the older adult population. All of these people may be 60, they may be 70, or they may be 80. So it's very important to consider markers beyond chronologic age to stratify older people. This is a summary figure from a recent, very well done epidemiologic update from the United States, which showed that older adults are now the most prevalent age cohort of people living with IBD in the United States. There are approximately a third of people living with IBD. And what you can tell here is that we're defining older adults in the field of IBD as those who are 60 and older. Obviously, this is a relative term, and that's why I like using the word older instead of something like elderly or geriatric. There isn't necessarily an age cutoff, but in the IBD literature, we generally talk about people who are about 60 or 65 years and older when we say older adults. This is a figure from a Canadian population based data, which projects that older people with IBD are the fastest growing demographic. The arrow highlights where we are now, so you can observe the differences in the slopes of the older cohort in the blue, the adult cohort in the yellow, and the pediatric cohort in the red all the way down. Well, we used to believe that older adults had milder disease and therefore we didn't have to focus on their management very specifically. We now know that this is not true. In this multi-centered retrospective cohort, what we showed was that when we account for disease duration, there was no significant difference in Crohn's disease behavior in adults diagnosed with IBD at older ages, those in the darker blue bars, compared with those diagnosed with IBD in younger ages below 60 in the lighter blue bars. And those in the green bars are those who've aged with the disease, so they've had this longer disease duration. The same was seen in patients for ulcerative colitis with regards to disease extent. Even after accounting for disease duration, there was no significant difference in new onset disease in adults 60 years and older in the dark blue bars compared with older adults in the younger adults in the lighter blue bars. So if older adults have robust disease as well, we should think about how the rapidly expanding therapeutic armamentarium of medications to treat IBD apply to this cohort of patients were about a third of who we see in adult GI practice. However, older adults are underrepresented in clinical trials of IBD medications. And while this is actually generally true of older adults in every disease state, in this analysis, we showed just how underrepresented they are. Fewer than 1% of adults in clinical trials of IBD medications that were published after the year 2000 and after were 65 years and older. And these are approved medications that we use in our daily clinical treatment. More strikingly, the majority of adults did not publish, the majority of the trials that we have actually did not publish subgroup analyses in older adults. So we don't know if there's a differential efficacy or safety profile, and none of the trials used function or another biologic age construct, either for inclusion or as an outcome. So always keep this in mind when reading a new trial for an IBD medication that's about to come out. With some of our older medications, we talk about lymphoma risk, but recognize that baseline lymphoma risk actually increases with advancing age. So consider that as you counsel your patients on a medication that may double their lymphoma risk. This is a nice meta-analysis that uses published studies to model the number needed to harm defined as an incident lymphoma, and they show it by decade of life. And so as you can see, with advancing age and decade of life, the number needed to harm drops dramatically. There's not much literature on methotrexate in older adults, but keep in mind that there are many drug interactions with methotrexate, and older adults tend to have more polypharmacy, and so this is a consideration. Additionally, methotrexate is primarily renally excreted, and kidney function is one of those things that does naturally decline with age. Monitor for subtle signs of chronic methotrexate toxicity, which we often think about things like pancytopenia, but it may be as straightforward and simple as fatigue. Other signs of methotrexate toxicity can include myalgias and hair loss, and a host of nonspecific symptoms, including dizziness and difficulty concentrating. All of the methotrexate toxicity I've seen has been incredibly subtle and in adults in their 70s, and so this is definitely a consideration. It's now well established that there are a relatively low rate of adverse events with the established biologic agents like anti-TNF agents and vedolizumab in older adults. This is a summary figure from an analysis we conducted in Medicare claims that demonstrates that the only significant difference between those treated with anti-TNF agents in the blue bars was a significantly higher incidence of infection-related hospitalization compared with those treated with vedolizumab in the green bars. Again, biologic agents have a relatively well-established safety profile in older adults. This is a figure from an analysis in the INATA registry looking at ustekinumab in older adults compared with anti-TNF agents, compared with younger adults rather. And they actually show no significant difference in steroid-free remission, which is a very clinically pertinent effectiveness outcome. And they also show no significant difference in a number of safety outcomes. What they do show is that there's a significantly higher risk for malignancies in those who were older treated with ustekinumab compared with those who were younger treated with ustekinumab. And in this cohort, it was very difficult to tease out the drug attributable risk of this, since older adults do have a higher baseline risk for malignancies. While we have no published data on risankizumab in older adults with IBD specifically, we can extrapolate data from ustekinumab and the psoriasis experience, where they have demonstrated that risankizumab is safe in older adults as well as effective in real-world studies. Now coming to small molecules, which are relatively recent to the IBD treatment scene. Naturally, there is a lot of concern with using JAK inhibitors in older patients. In this claims-based study, we demonstrated that there's an overall low rate of thrombotic events in older adults treated with tofacitinib in the red bars compared with anti-TNF agents in the teal bars. So again, while there should be some consideration and deeper counseling in our older patients in light of the oral surveillance trial. I think a recognition that these adverse events we're worried about are relatively low and they can be very effective medications for severe disease should be important to keep in mind. The newest class of small molecules approved for IBD are the S1P receptor modulators, as you may know. This is a table from a poster of a post hoc analysis from the clinical trial data. But note there's actually only 30 patients who were 60 years and older, and this was actually one of the trials that included a higher proportion of older patients. So it's very hard to come to a strong conclusion. I'm sure we'll have a proliferation of real world studies soon enough. But in general, what you see on this poster here is that there's not necessarily a numerically higher difference in adverse outcomes when you're looking at patients who are 60 years and older compared with patients who are younger than 60 years. This is one of my favorite figures, which illustrates, I think, a very important point. This is a figure from a retrospective pooled analysis of 4 clinical trials of anti-TNF medications used to treat ulcerative colitis. And what you can see is that older adults in the blue bars have higher rates of all adverse events compared with younger adults, those who were 60 and under, in the red and beige bars. However, when you focus in on just the older adults, what you see is that those who were in the treated arms in the darker blue bars actually have a lower rate of adverse events than those who were in the placebo arms, so older adults with IBD who were untreated or treated with placebo in these trials. And so it's very important to remember that the adverse events that we report in older adults when we talk about IBD treatments may not be drug attributable, but reflective of their higher baseline risk for adverse events. And I think what these data on this figure very nicely shows is the importance of adequately treating active IBD even in older adults. This is an updated analysis from the Danish National Registers, which demonstrates that older adults with IBD in the blue lines are less likely than younger adults in the red lines to be prescribed a steroid-sparing treatment option, both within 1 year and 5 years of diagnosis. And they show separately in the same analysis that there's an increased risk for surgery with IBD in older adults. So they're less likely to get effective treatment that's not a corticosteroid. That's the only bar where you see the lines are basically merged, but they are more likely to have surgery, which suggests that they do have robust disease. And perhaps this can be explained by prescription hesitancy. So in a case-based survey of over 400 gastroenterologists from over 40 countries, we learned that many gastroenterologists express age-based prescription limits for IBD medications, starting with the cutoff starting around 60 or 65 years or so. And so while this figure from the manuscript is actually not very clear, we know from the text that the highest hesitancy is for the combination of steroids, anti-TNF agents, and thiopurines, which is reasonable, followed by thiopurines alone, and then methotrexate. And so given what I said about these medications at advanced ages, that does seem to be somewhat natural. However, for those patients who are over 80 years, 15% of gastroenterologists globally were reluctant to prescribe anti-TNF agents, which is actually more hesitancy than for prescribing systemic corticosteroids. And not surprisingly, the study demonstrated that the lowest hesitancy was for prescribing vedolizumab. So while I don't endorse this website, I do think that this is a nice figure which demonstrates that prednisone is the riskiest medication we have for the treatment of IBD. So we as a community of gastroenterologists do seem pretty comfortable prescribing steroids to older adults because they've just been around for longer. We have a lot more experience with them. We do believe that we can taper off quickly. They're cheap, they're easily available. Our patients often ask for them. And so we are prescribing them more than the modern immunosuppressive agents because of the paucity of data, I think. But as I like to remind all of my patients, steroids are the most dangerous drug we have to treat IBD. I don't even think corticosteroids can really pass a modern FDA without at least a black box warning. And the initial approval studies were based on a very small number of patients, like 8 patients. So I think just putting drug approvals in context for the time that they were approved may be helpful for our patients as well when we're counseling them on their treatment options. Since older adults have a greater baseline risk for malignancies, considering how to manage IBD medications through malignancies is something to think about as we're seeing our patients increasingly. These recommendations here are very much my general interpretation and inclination, but should really be tailored to the situation and the type of cancer treatment the patient is receiving. And what you'll see on this table is that there's just a lot of the word discuss across the board. And I think that's really just reflective of the importance of having a partnership with the treating oncologist, understanding the evolving landscape of cancer treatments, which are increasingly targeted. So it's very possible that the treatment for their cancer will not control the IBD. Perhaps the medication to treat the IBD may increase the baseline risk for cancer. And so it might be time to consider a different treatment. Perhaps they're on a medication that would not at all interfere, and it would be very reasonable to continue treatment. But either way, it becomes important to have almost a phone-to-phone conversation with the treating oncologist to explain the IBD treatment and then to understand the cancer treatment and then make a decision together. So we'll end with some non-medication based considerations in providing comprehensive care for the older adult with IBD. Communication is critical with all of our patients. It is especially critical with our older patients. I won't read this list out for you, but these are some general, broad, geriatric specific communication strategies that could be beneficial as you're seeing your older patient. Since we do a lot of consent in GI, especially in IBD, where we do a lot of endoscopy, as well as discuss high-risk medications, it's important to use teach-back consent processes. We know that older adults are at a greater risk for mild cognitive impairment, and oftentimes that might not be detectable in routine clinical conversations due to multiple reasons, including the fact that people are actually able to compensate quite well for this. And so this figure here is actually modeled on surgical consent, but the same concept could really be used for any consent process where the physician provides some new information. This is the information about the procedure in this situation. And you frame it for the purpose of using teach-back techniques. And so we then ask for recall, ask the patient for recall and comprehension. Did they understand what we said? And do they seem to really understand what we're about to do and why and what the risks and benefits are? When the patient is able to repeat the information back using their own words, not just repeating the words that you actually did, then we, document or kind of say that there is some recall and comprehension, and you obtain the informed consent formally. But when perhaps the patient has not really captured the essence of what you're trying to convey in terms of risks and benefits for either the procedure or medication at hand, try to reframe it in a different way, provide an explanation, spend that time to do that, and then start again in checking the understanding and having the patient teach back. And this might need to be repeated a couple of times, but at least this way you're satisfied that you've obtained true informed consent. Quite frankly, this is something we should probably be doing for everyone, but very important for our older patients. Everyone wonders, when do we stop routine screening exams? And this is especially the case for IBD patients who get screened much more often. Using data from our center, we demonstrated that patients who had no prior history of dysplasia or cancer in the darker line had a lower yield on a colonoscopy after age 75. This is a routine surveillance colonoscopy. And so this highlights the importance of considering their history with surveillance colonoscopies in the decision-making on whether your patient needs continued screening. In this analysis, we demonstrate that frailty prior to immunosuppressive treatments for IBD confers a greater risk for infections, and this highlights the importance of taking into account a person's overall functional status and health. That being said, in another analysis, we found that the response to anti-TNF treatment may, in fact, improve pretreatment frailty. And while this is a small exploratory study, this highlights the bidirectional relationship between frailty and effective IBD treatment. So don't let functional status alone be the reason to withhold effective treatment. We also know that older adults are at a greater risk for bone loss at baseline, and this is especially the case with an inflammatory condition, specifically like IBD. So I pasted here recommendations from different societies on screening for osteoporosis in older adults with IBD, and you'll see that nothing is really conclusive here. So I think a simple rule of thumb is that all patients 50 years and older should have been screened at least once for osteoporosis if they have IBD, understanding that IBD itself, independent of corticosteroid use, is a risk factor for decreased bone density. When you're seeing your older patient with IBD, keep in mind that the sequelae of the disease that are present again in all adults, such as joint inflammation, social isolation from the limitations of a diarrheal condition, falls due to bowel urgency, are likely due to be magnified in older adults. So it's important to think about them and address them. And along these lines, coordinating care for older patients becomes more critical as well, as they do tend to have other subspecialists and other chronic conditions that might require care coordination and prioritization. And also remember that the average American PCP is quite overwhelmed. So take it upon yourself to coordinate the disease-specific and drug-related primary care that may be needed. Lastly, I'd like to leave you with a reminder that older adults may have many individual and systems level barriers to care that prevent equitable medical care, specifically for their immune-mediated inflammatory disorder like IBD. And we highlight this in more detail in this recent piece. And so just think about these barriers that may be present as you're seeing your older patient. So in summary, I'd like to emphasize that older adults with IBD are not a sort of quote unquote special population. If you're an adult gastroenterologist, they're probably about a third of patients you see in your practice. It's very important to treat their disease and not their age. And so what I mean by that is putting into context to our older patients that everything in life comes with risks. They are at a greater baseline risk for adverse events, likely due to advanced chronologic age or other comorbidities. And yet the importance of effectively treating their disease can be very impactful. And I think if you explain it well, older adults actually have the perspective to appreciate this. It's important to spend time, given the fact that a lot of this is not as evidence-based as some of the medication treatment strategies that we have for our younger patients. And so explaining some of the gray areas could be very helpful in treatment decision-making. And lastly, do advocate for equitable care for your older patient as they are quite vulnerable. Thank you very much for your time.